אוקיי, חיכינו את השלוש דקות המטכ"ליות שלנו, אז אנחנו שמחים מאוד מאוד לארח היום שוב את פרופסור צ'רני, מנהל היחידה לטיפול תומך במרכז הרפואי שערי בירושלים, מורי ורבי האישי ושל רבים מאוד שנמצאים פה על הזדמנויות למחקר בטיפול תומך. תודה רבה פרופסור צ'רני, הבמה שלך.
Okay, thank you very much. Let me just find my slides here. There we go. Okay, I'm going to try to make this a very, very practical talk, giving you both the idea being to both walk you through the spread of different sorts of research that can be done in palliative care, and possibly also to trigger some ideas. In our field, research is important to for the purpose of continual quality improvement, to try to continue to improve on our ability to help patients, and sometimes this is going to be through the development of better understandings of patients, better understandings of treatment, better understandings of our working systems. Either way, progress is not made on guessing, and it's not made just on intuitions. Palliative care is one of those areas where unlike something like medical oncology, where there are anywhere between 40 to 50 new technologies coming on a year, palliative care evolves much more slowly, but there is a constant evolution of knowledge. There are multiple different ways to do research in oncology. There's a quantitative techniques such as randomized studies and surveys, qualitative techniques based on in-depth interviews. We're going to talk about different sorts of reviews that can be done, implementation studies, and studies in public policies. This is an overview of where we're going to go. Well, so let's start out with different quantitative research methods. These are by definition research based on the collection and analysis of numeric data to try to identify patterns, correlations, and associations. Often we will use these to measure specific outcomes such as pain, symptom control, and patient satisfaction. And this can be done using different surveys, questionnaires, and standardized tools. And the idea is to gather data from a very large sample size so that ultimately you'll have data which is generalizable, that from the study group that we can generalize the knowledge to a much wider population. The limitation of quantitative data is that you only get information pertaining to what you ask, and often that means you don't get a lot of the complexities and the subjective experiences of patients, and which is better acquired through qualitative research, through in-depth interviews. So of quantitative research, the first thing that I'd like to talk about is sort of the gold standard of research in treatment methodologies, and these are randomized controlled studies. These are designed to evaluate the effectiveness or efficacy of new treatments compared to the standard of care. The idea of randomization is to try to reduce bias. And in a randomized study, patients are closely monitored with a structured assessment process to gather the data of particular interest. So, in an analgesic study, this may be data about pain or pain-related interference with function or quality of life. And you know, the different outcomes will depend upon the specific issue being studied. I'm going to show you two examples. I think that you'll probably be familiar with both of these. The first one was a very now famous study of randomizing patients between standard care, lung cancer patients between standard care and having a program of early palliative care. And the endpoints that they were looking for were primarily looking at quality of life, anxiety and depression, and survival was a secondary outcome. And what they found was that in the patients that received the early palliative care, they had an improved quality of life using the FACT-L scale. The patients having early palliative care had over time less anxiety and depression than the patients who did not. And this was the big surprise of the study, but they also found that the patients having early palliative care had a very substantial survival advantage with an improvement in median survival. So the conclusions were that amongst patients with metastatic non-small cell lung cancer, early palliative care led to significant improvements in both quality of life and mood. They also had less aggressive care at the end of life and longer survival. Now, this obviously became very practice changing. Another recent important randomized study was a study comparing a three-step analgesic ladder, the traditional one of the WHO, to a two-step analgesic ladder, which essentially skipped the middle step. This was an international study, and amongst the participants, you'll see here was Ron Sabar. And in this study, they found essentially that there was no difference in the speed to which one could get pain control between a three-step ladder and a two-step ladder, and also that there was no difference in side effects. Excuse me. Okay. Another form of research is, in terms of quantitative research, are patient surveys. And these are structured surveys to look at either patient needs, patient preferences, and particularly patient unmet needs. I will show you an example of a survey that we carried out a number of years ago now with patients in the oncology outpatient department, where we surveyed them about their communication preferences. And we had a structured interview and a questionnaire with 103 consecutive patients. And we had some really interesting data. One of the questions we asked about was the issue of communication, that with eye contact, that 87% of patients agreed or strongly agreed that it was important for the doctor to maintain eye contact. In terms of where the doctor should sit relative to the patients, 53% were quite happy with the doctor sitting across the desk. Another 40% said they much prefer to have the doctor sit next to them. The most interesting one was related to supportive touch. 48% of patients were in favor of the doctor holding their hand or touching their shoulder when talking to them about a sensitive issue. An equal number disagreed, and with 50% saying strongly disapproving. But the interesting thing with this story was that when we looked at that, looked at the data looking at sex and religiosity, the group that most strongly endorsed supportive touch was the religious women, and this was so counterintuitive. We went back to them to ask them why that was, and they said that although in regular life they don't have people touching them, that in the context of a high stress situation and in a medical context, to have the touch and support of their doctor was very meaningful for them. And they said that this is a question that they didn't ask their rabbis about. When asked about how they like bad news communicated, 92% that they'd want to have that they did want the information conveyed to them, and overwhelmingly with sensitivity to their emotional response. Only a small proportion, 6%, said they want the information given to their family members and not to themselves. So this underscores the importance, or we learned from that the importance of asking patients how they want information given and who they want it given to. Now, clinician surveys also can be very helpful. Clinicians' needs, knowledge deficits, their attitudes, and their coping are all things that affect patients and patient outcomes. I have been involved through the European Society of Medical Oncology with a number of these. This was one looking at the attitudes and behaviours of oncologists regarding truthful disclosure of information to patients with advanced and incurable cancer. There were some issues where there was a lot of consensus. There were some issues that everyone disagreed with, and there were some things that where there was no agreement. So things with high agreement were competent patients to decide who receives information about their diagnosis. Most of my patients expect me to tell them what is the most appropriate treatment. Interesting that the patients wanted a paternalistic approach. Physicians disagreed that it's not their job to talk about palliative care. Most of them did recognise that that's important. There were some who felt strongly that it was not their job. Most of the doctors felt that they were not irritated by patients who come with lists of prepared questions. The things where there was no consensus were interesting. When discussing prognosis, I try to be as general as possible. There was no consensus. It's important to convey hope for recovery, irrespective of the situation. So there were many doctors, about almost 50% who agreed, and on the other hand, 40%, another 30% who disagreed. The treating physician should decide how much information the patient should receive. Again, was very split. And I guess this one almost contradicts the first one about where we were asked if the patient should decide. So this was also very, very interesting and useful data. Ultimately, we ended up looking at the influence of different cultures, and we found that the attitudes were very different between the Mediterranean countries and Eastern European countries and the Western European countries. In that same decade, Rama Sapir, my former colleague, carried out a study of physicians in Israel about their knowledge and attitudes to the management of pain, to management of cancer pain. And we did a big survey in Europe looking at the attitudes of medical oncologists towards palliative care and their involvement in it. And both of these were substantially practice changing. Now, in contrast, The qualitative research majority is when you're sitting down, talking to patients, recording the dialogues, and then analyzing the patient responses. So you're trying here to explore the subjective experience perspectives of the patients to try to get as rich narratives as possible. And this is done either through interviews, focus groups, or sometimes where there is an external participant observing an interaction going on. And the usefulness of this sort of research is to get deeper information about the emotional, psychological, and spiritual sides of either the patient experience or sometimes even the staff experience. The limitations of this sort of methodology, this methodology gives you depth, but because the sample sizes are relatively small, the issues of generalizability are more difficult. So this takes you deep into subjects, but one can't necessarily make broad generalizations from it. Craig Lindemann, who's there's an interesting story. Craig studied medicine in the American School of the Ben Gurion University of the Negev, and he did undergraduate palliative care training with me. He then went on to do family medicine and palliative care, and he's now the chief of palliative care at Sloan Kettering, where I had trained 35 years ago. And Craig came to Israel to do a study with me about existential issues in cancer patients. And he did in-depth interviews with 40 patients, exploring issues of autonomy, dignity, body image, isolation, their coping mechanisms, issues of remorse and guilt, their spiritual health, how they find meaning, and their attitudes towards death and dying. And from this, these were the 40 patients, and just some basic information about them, their age, their sex, where they were born, Christian, Muslim, their religion, marital status, work, their native language at home, their diagnosis, what treatments that they were having at the times of the interviews, whether they had pain or the pain was well controlled or not controlled, and how long they'd had their cancer. And let's just walk through this story. On the issue of death and dying, about half the patients reported that they thought about death and dying more after the diagnosis of their cancer. Some patients expressed fear and anxiety about death, while others approached the subject with calmness and expressed that they had found a way of coping with unknown future. And then the generalization is then followed by examples. When it's my time, God will take me. I'm afraid of dying, and nothing can help ease my fear. One patient said, Louise Ferdinand Celine wrote that the best cure of life is death. Patient 18 said, lately I've been thinking about it. I don't want it to happen, but I'm not afraid of it either. Patient 19, I think about death, but I'm more realistic about life and not deeply frightened by death. The good prognosis helps ease what fear I have. Patient 20, I always think about death. It's natural to think about it. One day everyone must die, although I do worry that my children will grow up without a mother. Some stated that they were worried about, 18 patients said they didn't think more about death after the cancer diagnosis, but a group of them said that they were worried about pain and suffering associated with dying and not about death itself. And then he gives a series of quotes. I'm not afraid of death, I'm afraid of suffering. I'm only afraid of the pain. I'm afraid of what the future will be like regarding pain and losing my intelligence. I have no fear of death. I've seen much death in Poland. I've seen more death than life. I don't fear death, but I do fear pain. So the quotes illustrate the generalization that's identified. Overall, what the study found was that that many patients said that they'd enjoyed the opportunity to talk about these ideas. And the most striking finding was that despite the prevalence of existential concerns, manifested distress was relatively uncommon in this group. And they hypothesized that this is because of very strong family structures. And the patients who were most distressed were the people who were very socially isolated. Okay. Now, moving on, I'd like to talk a little bit about systematic reviews and meta-analyses. This is a task where you try to synthesize and analyze all of the existing research studies for a particular subject. Now, if one looks at the ESMO guidelines on constipation, confusion, and fatigue, these are all systematic reviews where they've taken all of the data, analyze the strength of the data, and then try to pull conclusions together from allocating all with all the data together. Similarly, if one looks at the Cochrane reviews, these are all excellent examples. So by pulling the data from multiple studies, one can get more a robust understanding of the efficacy of specific interventions, treatment modalities, or care models. Now, doing a systemic review is a complex and a very laborious process. So you have to have a very clear objectives, what it is you're looking for. You have to describe the information sources and do an electronic search of the databases to try to get all of the information, and then also look at the references to find other sources. One needs to assess the quality of the studies, because you can have lots of evidence, but it may be weak evidence because the studies were not good quality studies. So you need to discuss how bias may have affected the assessments. Then try to synthesize the evidence with a planned statistical method to evaluate it, and then based on both the data and the risk of bias, interpret the findings. And I would encourage people to look at some of the Cochrane reviews in palliative care, say on the use of stimulants, or the use of opioids for neuropathic pain, and these are excellent examples of very good systematic analyses. I conducted one systematic analysis a number of years ago, which was looking at how people had carried out best supportive care studies in oncology, and there were multiple studies, and the bottom line was that what they called best supportive care was rarely described. They used no reference standard. They didn't use structured symptom reporting. They didn't credential for supportive care capacity. There was no standardization. So essentially, it was a failure to use any established standards. And this had big implications for research studies using a best supportive care arm. This systematic review strongly suggests that there are problems in the ethical and scientific validity of many of these studies. The results should be interpreted critically with the awareness of the potential bias that was introduced by the lax methodology. Future supportive care research endeavors need to be more compliant with ethical standards for research and have more positive social value. This had multiple implications for researchers, ethics review boards, and publication process. Now, a different sort of consensus document is a Delphi consensus process. And this is where you take a subject, you gather together a large group of experts, break the subject down into different assertions or claims about it, and to see what are the things where experts agree and what are the things that they cannot agree upon. So you define the problem, invite your participants, have an initial questionnaire, and then depending on the feedback, where you define where there's subjects where there's consensus and where there's not consensus. Change the questions until you can get a broad consensus over a wide range of issues. This was one that was done to define consensus-based standards for best supportive care in clinical trials with 36 experts. And ultimately they achieved consensus on 11 statements in 4 domains. These were the domains: multidisciplinary care, documentation, symptom assessment, and symptom management. So what you can see here is going through the rounds. They started out with round one, and they went through 6 rounds until they revised the consensus statements to get the thing to where there was a very strong level of consensus. This was the process that was also used for the revised standards from the European Association for Palliative Care for Palliative Sedation that were published a couple of years ago. Implementation research aims to look at how effectively can one implement a new intervention. And the idea here is to continually collect data for continuous feedback, reflection, and adaptation. So this is essentially learning as you're going. Now, this was done with a project that I was involved with an organization which is now called Canopy Care. It used to be called XPain. This was developed by some Israeli developers. And this was giving a telephone-based tool for patients to give feedback about their distress, symptoms, and adverse events. The information would go to a desktop for nurses, and depending on the severity of the reports, the computer would already triage these to urgent, overdue, and mild. So to try to triage who are the most important patients to call back. And the idea was to get rapid resolution of problems. The nurses would have also in front of them an evaluation and triage pathway for a whole lot of different symptoms on the computer. And they could triage between either doing a telephone consultation, an expedited in-person review, or an urgent in-person review. It became a code red. So something which would be a code red would be, did your shortness of breath worsen suddenly or gradually? If the patient said suddenly and severe, that would flash up on the screen. This needs immediate attention. The patient needs to come in immediately. So the procedure was that the patients were given who were having treatment were enrolled in the process. They were taught how to use the program on their telephones. They developed the algorithms for triage between the levels of urgency. When it was initially trialed, it was trialed in 800 patients over 6 months. And what we found was we got 29,000 symptom reports. 31% of them required action, mainly by telephone action. Only 6% required a follow-up office visit. Most of the patients kept on using this even at 88 months. They had a 22% reduction in hospitalizations, and because problems were being dealt with earlier, and also because symptoms or side effects were being dealt with earlier, patients were staying on treatment for longer. So this was an intervention where we could rapidly show that it was changing and improving practice. This is just the retention rates. Most patients, interestingly, the older patients stayed on and were more compliant than younger patients, and this was a surprise. How frequently did patients report? About half the patients put in reports 3 or 4 times a month. The symptoms which were most common in the reports were high levels of distress, pain, weakness and fatigue, nausea, shortness of breath, diarrhea, and chest pain. Now, another area, and I guess the talk that I gave last week was an example of that, and this is what I would call conceptual research. This is research that focuses on abstract ideas, theories, or concepts rather than on empirical data. There is clearly a philosophy behind palliative care, and the aims of conceptual research are to enhance theoretical understanding, refine existing concepts, to propose new conceptual frameworks, and to generate new hypotheses for testing. The hope material stuff that I discussed with you last week was one example. This was another example where I did a conceptual analysis of different sorts of autonomy. The paper opened up with a story. Mrs. Kimat Met, a 37-year-old ultra-Orthodox Jewish mother of 2 small children, presents with metastatic pancreatic cancer with extensive liver metastases. She's weak and cachectic. Given the very advanced disease and her poor performance status of presentation, the outlook is poor, and the likelihood of substantial benefit from chemotherapy is small. The patient, the family, who was told of her diagnosis by the diagnosing surgeon, requests that you not tell her how serious her condition is. They explain that in their culture, any information should be given to the husband, and that he and his rabbi will decide what's best for her to know. At times, when her family is not being present, the patient has repeatedly remarked to the junior doctors that she wants to be told what's happening to her. You, the attending of record, sit by her bed and take her hand. She turns to her pillow and looks you in the eye, squeezes your hand and says, I want to live. I need to see my children grow up. I need you to give me hope. I'm the sick one here, but I feel like no one is talking to me. Questions abound. Are you going to tell her what's going on despite the explicit request of her family? How much will you tell her about the grim prognosis and the low likelihood of benefit and the potential for harm from treatment? Does her plea for hope demand that you hold back on discussing the full scope of the impending tragedy? Without all the information, how could she possibly make an informed decision about whether to receive treatment or what will probably be ineffectual and possibly harmful chemotherapy? So these were the questions that this conceptual paper explored. I'm going to walk you through this a little bit, that essentially we could break down autonomy into multiple different sorts. There's firstly a pure self-interest autonomy, where people make decisions just about what they consider is most important for themselves. But more often than not, patients have got families, they have obligations and duties and interdependence with their family members, and because they will take their family's opinions into consideration, and this is called relational autonomy. In some situation, the patient either perceives that it's not their role to get information, they consider the information harmful to them, or they want to reduce their burden of information overload. And they'll say, I don't want all the information. This is called voluntary diminished autonomy. And this can be expressed either by saying, look, don't talk to me, talk to someone else in my family, or talk to me, but I don't want to have all the details. A diluted disclosure of distributing information or delegated autonomy. And similarly, through relational autonomy, you can sometimes get to these same conclusions. And what's really interesting is the impact that it's culture and values that impact on how important relational autonomy is. And it's the same issues of culture and value that often lead people with different considerations, harm reduction, perceived role, and burden reduction that lead people to voluntary diminished autonomy. And these are all different colors of autonomy. Another area of research is public policy research. The delivery of care in palliative care is very strongly related to public policy. And the aim here is to generate evidence-based knowledge that can inform decision-making process to get better public policies. So the example that I'm going to give you is the availability and the regulatory barriers to accessibility of opioids for cancer pain in Europe. And this was the first of a series of studies that I was involved with, both with the European Association of Palliative Care and ESMO. And in the upper box is all the countries of Western Europe, and in the lower box is all the countries of Eastern Europe. And you can see that all the black areas are places where opioids that were not available, and the red is where they're only available at full cost. The blue indicates that they're free, and the green is partial. Patients need to pay for them partially. So we see big differences in the availability of opioids between Eastern and Western Europe. And then we looked at the maximum number of days that can be prescribed in a single prescription. And again, in Eastern Europe, it was often less than a week. The red is less than a week. In Western Europe, you could generally get a month or more. Opioids, where can you get them from? Are they available in any pharmacy? In Western Europe, yes, and in Eastern Europe, absolutely not. In Eastern Europe, they're either in designated pharmacies, hospital pharmacies, or regional pharmacies. And this very large data set had major implications for policy, particularly about the opioid regulations in Eastern Europe. And this was the basis of a lot of policy reform that subsequently was developed. So, what I've tried to walk you through is that the research in palliative care is not just about doing randomized studies. There are lots of different avenues and options in terms of doing research, and the key issue is to find a question of substance. And these could be questions that arise in our own settings, where possible to work together, to put together teams to do this. There is funding there are calls for research. There are currently calls for research submissions through Ben Gurion University in palliative care. And there's also funding also available through the Israel Cancer Society. So thank you very much for your attention, and I'm more than happy to take questions about any of these different approaches. Thank you very much.
Thank you so much for that overview. It really gives a clear picture. I'll switch over to Hebrew. If anyone have any questions, you're welcome to open your microphone. So I'll start off if that's okay. You have a very clear picture of where we stand now in the research world in palliative care. I think a lot of change has changed over the years. Are there any gaps that you see now that would be relevant, especially in the Israeli setting, that you would say it would be worthwhile to invest time and effort into?
Well, I'll give you an example from our own setting. In our own setting, in the hospital, we have about 4,000 deaths a year. The palliative care service sees about 2,000 dying patients a year. Okay, we want to know what happened to the others. How were they dying? What were the symptoms? What were the issues? Okay, to try to see who were the patients that may be falling between the cracks, or are they issues of sudden death that that were not necessarily predictable? So looking at which is the question of certain departments aren't referring, certain sorts of problems aren't being referred. We don't know, and getting this information could potentially be practice changing for us.
So, another question: have you experienced? I mean, it seems a lot of us have experienced lately difficulty in getting papers published, especially in European journals lately. Is that something that you've noticed, have experienced at all?
I've not. I am on the editorial board of palliative medicine, the only related paper that I was involved with was someone who wrote a really inappropriate and hostile editorial, which was totally rejected. So no, I've not encountered that. We did encounter one issue with the Oxford textbook of palliative medicine, where we had one author. This is the same person that had submitted this toxic editorial had previously been asked to submit a chapter to the Oxford textbook, and she refused, saying that she wouldn't submit a chapter to a textbook that had an Israeli editor. But she was happy to try to send a poison piece to a journal with an Israeli editor. So she has no consistency, but that is the only issue that I've encountered. So I don't perceive that to be a real barrier. And on a personal level, the Hope paper has gone through well, and I think that I do think that and the papers, places like Iran and Palestinian palliative care people, they also have publications, and I don't think the journals are politicized. That's been my experience up until now.
Yeah, sure. Any questions?
I would like to ask one. Hi, Nathan. Great lecture. Thank you. I wanted to ask you if when you look for information, do you nowadays look at information for research and for asking questions differently in the using AI, or you still work as like before? How that impact your work?
No, I guess my work follows my interests. And often one interest will lead into another. So and I'll give you some examples. My interest in bias and weak data led me into exploring overtreatment. The issues about hope in overtreatment led me, in realizing that the hope literature had, was not well collated, led me into saying, well, let's try to pull together hope literature. And most recently, I've been dealing with how do we know what we know, epistemology in oncology, and dealing with uncertainty in our decision making. That you have not only uncertainty about how individual patients respond, but we also have evidentiary uncertainty, where even the evidence that we have has variable levels of uncertainty depending on the nature of the study and biases that may or may not have been introduced into the study. Through interacting with other people and one gets the ideas capture my mind that I want to explore, and then it is also what I can do feasibly. So feasibly, I know that I didn't have the resources or numbers to do randomized studies, and I didn't try to do randomized studies here, but I did have a very I had a good database in cooperation with the European Association for Palliative Care and with ESMO, which that gave me access to large numbers of people to try to do survey work with. So it's a question of using the resources that you have available to you. And as the palliative care services grow here and services are seeing larger numbers of patients, we're in a better position to explore different interventions. Like your group has a group that has a clinic specifically for families, I believe.
Right.
Okay. And the accumulated experience from that, or to look at what are the specific impacts of that, would be a really important question. A number of years ago, one of my nurses did a master's program, and we followed patients, the family members, both before and after their family members had palliative sedation, looking at what their concerns were before, and then after the event, what their thoughts were, whether they were happy with it, or whether they were frustrated, whether they saw this as how they perceived it, were they comfortable with the decisions that had been made, were they comfortable with the level of the information they'd received. And that was also gave us really important and useful data.
Thank you. Great talk. Thank you.
Okay, if that's all the questions, thank you so very much. It's always a pleasure to have you, Professor Czerny. Learn so much from your experience and knowledge. Thanks again.
בבקשה.
נפגש שבוע הבא, וההקלטה תעלה בימים הקרובים ליוטיוב. תודה. להתראות, שבוע טוב.
Okay. Bye.